from the American Academy of Pediatrics.
Talking about social media can make kids and their caregivers anxious and uncomfortable.
The Center for Excellence on Social Media and Mental Health has a new set of tools for us to share with families.
Really, what we do in child development or in adolescent medicine is say, let's get inside that kid's mind. Let's try to understand them and know what's driving them towards media.
Plus, the latest issue of Pediatrics takes a deep dive into quality improvement.
Of the 4 primary measures that were selected by the project leaders, 2 of them exceeded 90% adherence, which is really impressive for a national QI collaborative.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Pargavalinki.
And I'm Dr. David Hill. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Today's episode has a very special say so stay tuned. But we'll start with a look at new tools for managing social media.
Back in episode 157, we had Doctors Jenny Rudesky and Megan Moreno on to discuss social media and mental health. Since then, those two have been very busy.
Between managing the AAP's Center of Excellence on Social Media and Youth Mental Health, appearing before Congress, helping with updates to the Kids Online Safety Act, and making a ton of educational videos that are also entertaining, I'm not sure how either has time to surf the internet.
How do media experts engage with the media? Now you got me wondering, Joanna. But there is so much to discuss. I'm particularly interested in the policies that are now shaping children's experience with media and how to talk to families about media use, because it feels like everything is always changing.
Let's get our listeners reacquainted with Drs. Rudesky and Moreno. Dr. Jenny Rudesky is the director of the Division of Developmental Behavioral Pediatrics and associate professor of pediatrics at the University of Michigan Medical School, as well as chair of the AAP Council on Communications and Media.
Dr. Moreno is interim chair of the Department of Pediatrics at the University of Wisconsin-Madison, where she runs the Social Media and Adolescent Health Research Team. And they are co-directors of the AAP's National Center of Excellence on Social Media and Youth Mental Health. Drs. Rudesky and Moreno, welcome to the show.
Thanks for having us. It's great to be back.
It's good to be back.
You heard me mention the Kids Online Safety Act, or KOSA. Recently, there were updates to this. Jenny, can you explain?
Yeah, so KOSA was recently changed based on some feedback from advocates to make a couple things that would really address some of the concerns that especially LGBTQ plus advocates had about how it could inadvertently harm or restrict kids' access to the content in the communities that they really need to kind of thrive and understand their identities. So the biggest change is how KOSA would be enforced. It would no longer be mainly the state attorney generals who would each individually be interpreting what is a child experience of harm online and how should we enforce it. It would be centrally at the Federal Trade Commission, who would be, given more expertise to both evaluate how are platforms doing with monitoring the harms and the well-being of child users, and also to then do enforcement actions.
Does KOSA include banning online social media platforms like TikTok when they're outside of federal oversight and regulation?
No, this is totally different from the TikTok conversation. The TikTok ban, as it's called colloquially, is really more about lawmakers' concerns that TikTok, owned by ByteDance in China, somehow might have the data of American citizens and that might be somehow accessible to folks in China. And our online activities, especially for short form video platforms like TikTok, where it knows a lot about us, like how grumpy am I feeling today? How much am I staring at delicious food today? How much am I following this sort of politician versus that sort of influencer? And so they rightfully want there to be data security over who has access to all this knowledge about us. So really that TikTok bill is much more about where that data is stored and who governs it. KOSA is totally different. It is much more about establishing some accountability for tech platforms where we know kids are spending a lot of time, to both be recognizing, okay, kids are here, kids need different experiences on our platform. They may need different designs, different privacy settings. And it's trying to make sure that companies are following those sort of best practice standards that really more follow the needs of children.
And I wanted to jump in to say one thing that's interesting to me as an adolescent medicine doc across these different areas of legislation is how in the know many youth are about specific bills, specific proposals. I mean, often they're more in the know than their parents are. And so I think it can be a really great opportunity for folks who are parents as well as folks who are pediatricians to even keep an open ear and an open mind to hearing from your patients or your kids what they think about these laws and proposed areas of new legislation.
Yeah, we actually got a question on our Center of Excellence question and answer portal from a teenager asking what the pros and cons of different policies are, specifically about some of the more restrictive policies like the Utah bill that would require parental consent for a teenager to have a social media account. So we took a lot of time and effort to write out a response that we hope would be understandable to teens and to parents about what are the different types of things that are being talked about in policies around kids and technology right now. What are the different ingredients that are really important, such as data privacy? And what are the things that don't necessarily reflect the science, like being really restrictive and blocking kids' access? So I welcome people to go to the aap.org/social media website where you can find our response to this question, because I think it really distills it in a way that's hopefully more digestible. Policy speak just turns a lot of brains off. So we really wanted this to be something understandable to families because there's a lot at stake and it really could help impact the way young people experience social media.
No, I think everybody's probably really glad we're reviewing these policies and also talking about what is great, because it seems like the current discussion around media and social media is that it's bad somehow for kids. I mean, we know this is not true, but how do we flip this narrative? Megan, do you have any tips?
I think a lot of the current narrative has focused on these devices and these social media platforms as inherently bad or inherently addictive. And I think one of the real downsides of that narrative is it really removes the agency and the curiosity from both youth and their parents. We know that parents are on social media, almost as much as kids these days. And I think for such a huge proportion of our population to be engaging in a behavior that then they're told is bad is really not a healthy lens to help people figure out what is actually working for them when they're interacting with platforms or apps. I think it just really strips them of the agency that they have to be able to say, I'm enjoying this experience, I'm not enjoying this experience, I'm going to make these decisions differently. And when they're feeling, oh, whatever I do, it's bad anyways.
Yeah, and I'd say if there's a couple ways to really flip the conversation, I wouldn't focus it on just these broad ideas about social media and screen time, right? Each one of us has a totally different Instagram feed or TikTok feed. It's all based on what's known about us and how they tailor content or advertising to us, right? So one way to have a conversation is to say, what does your feed look like? What is mine? What do we think these platforms know about us? How could we change our feed if we wanted to? Because that is one of the concerns about how the business model underlying social media platforms, where they're hoping to collect data and be able to target marketing at people, at users, including teens, has had some unintended consequences of some teens then getting more targeted with certain unhealthy content that they didn't search for, but wound up more recommended based on their behavior. So that's where you'll hear more concerns around like the eating disorder advocates or, kids who are depressed or experiencing thoughts of self-harm. When a platform can read that about you and then tailor content that really builds upon that, that is where people are most concerned about the harm between who's that individual child and what are they struggling with, and then how is that shaping the way the feed reacts to them. And then the second way to flip the script is just also about design. It's not just about all these social media platforms are designed in really different ways, and they have more and more features that let us do things like change our feed, put on timers, which, teens tell us aren't totally effective. But there are at least things we can experiment with, right? And we could say, you know what, I'm going to turn on that tool. Let's meet again in a week and see how that felt. And that gives you much more agency of saying, sometimes I love this platform. Sometimes it drives me crazy and makes me feel bad about myself. The more you can try to make little changes and see how it affects you, that's a really important reflection practice of what is my relationship with social media. And that's going to help us much more with behavior change than just these kind of broader conversations about social media is all good, social media is all bad, let's ban it, let's give it to everyone. It's such an individualized conversation.
I love these tips on how to have these conversations because I am always looking for better ways to engage families in the clinic when we're talking about media. The Center for Excellence has now provided something we're calling the 5 C's: child, content, calm, crowding out, and communication. Megan, can you tell us about the first 3 of these C's, maybe? Child, content, and calm?
I'd be happy to. The first C of the child really builds on what we were just sharing, that we really want these narratives and discussions to be centered on the child rather than on a device or a platform. And I think it also really recognizes that every child's experience navigating media over time for themselves and also differences between kids. And so really focusing on what are the needs of that child, where are they hoping to go with their media experiences, really trying to understand their experiences rather than making a blanket, oh, let's take the phone away, you had one bad thing happen. So really doing what parents do well, which is centering on that child and what their needs are and how they react and how you can support them through their experiences. The second on content gets at the recognition. I'm going to build on what Jenny shared. We used to spend a lot of time talking about screen time, and now we really have come to understand that not all screen time is the same. And what we've learned through many decades of evidence is that the content really matters. And you can even do a thought experiment of thinking about what kind of content your child might see on PBS Kids versus what kind of content your child might see playing Grand Theft Auto, for example. And that really helps illustrate that how kids spend their time is really important. And then for calm, I think it's a recognition that across all ages of children, as well as adults, many of us can reach for media for moments to calm ourselves. And I think that we need to have some grace with that. But also when we think about children, we want them to have a robust toolbox of ways that they can calm themselves and working to support that child in developing many other ways that they can seek to calm themselves in moments when they need it.
I am guilty of watching reality TV at night to decompress, so I feel that calm. And Jenny, what about the last 2, crowding out and communication?
Yeah, and just some backstory on why we developed these 5 C's, this little kind of like mnemonic for pediatricians and pediatric clinicians to remember, is that we were getting questions of like, well, listen, my toolbox for talking about media was the 2-hour rule, like 2 and 2, not under age 2, no more than 2 hours. I need something easy to remember that I can access when I'm in the moment of that pediatric visit. So we're hoping 5 C's is not too many. It's really built upon this great educator named Lisa Guernsey who came up with the 3 C's. Child, content, context, which was more about the family context. So we asked her if it was okay to build them out, to add a bunch of other ones that we think are going to be pretty easy to implement into the conversations you already have in clinic. So for example, just to go back to calming, like you're talking about sleep. You're talking about how do you de-stress after a school day? Tell me what your afternoon is like. How do you calm down when you get big emotions? Like it can easily be part of that conversation. When it comes to crowding out, that's the 4th C. This is talking about, okay, when we are using media too much, and that's not all our fault, right? Media has a lot of what we call engagement prolonging designs or extended use designs. These are things that just make it hard to put media down because the companies make more money if we spend more time or click more. So we want families to recognize what are some of those designs like autoplay, infinite scroll, things that kind of reward you for coming back more, and try to minimize those. And then recognize a big motivator for changing media use behavior is, what is it crowding out? what do I love doing? What does my family love doing that we're just not doing as much of? Because the default easy option is just to, pick up our devices or put on the TV. So this is so individualized for families. Some love to take walks. Some love to, put on music and dance. Some love to cook together. For a lot of them, it's going to be sleep. I feel so exhausted when I haven't gotten enough sleep. It just makes my day so much harder. These are the ways you help motivate and do that motivational interviewing, because all families have their own goals. And if media is crowding that out, you work together to figure out how to push it a little bit to less of the media use that's doing the crowding out and more of the thing that they want. And then lastly, the 5C is communication. This is stressing to families how important it is to talk about media. It shouldn't be a taboo or a guilt-inducing or a panic-inducing topic, even though the current headlines often make it feel that way. This is something you can talk to your kids when they are infants and toddlers. I know that sounds crazy, but you can just be saying like, all right, you know what? I've been on my phone too long. I'm going to put it down. Talk out loud about what you're doing on your phone as a parent so that they understand how you're trying to balance your phone use, what you're using it for, the good purposes. I'm going to de-stress right now. This day has been a lot. I'm going to go get on my phone for 10 minutes and then I'll come back and hang out with you guys. And then the communication as you get older. I mean, kids who are school aged, 8, 10, 12, they have so many cool ideas about media. And then when you get into the teen years, like they have so many opinions. These should be awesome, fun conversations with your kids, or maybe not necessarily fun, but like really critical. Like, what's going on here? Why did that person tweet that? Why is that influencer acting that way? Or to share experiences like, oh my gosh, I saw this funny, like the funniest video today. Let me show it to you. I'm following this new amazing, creator. When we talk with kids, number one, they feel heard, they feel understood. Number two, we get a window into their digital lives that we don't get if we just see them looking at their phone. And number three, this is a huge part of mental health, just being able to talk in an open-minded way and listen to your kids and help them feel understood. So media is just interwoven with all of those daily experiences where they may want to vent about someone who did something, crummy at school that day. And it might be online, it might be offline, and both. But, it just opens the space that they know they can come to you. And that's a really important habit. If there's like one thing of these 5 C's I would want families to start doing, it's this communication piece.
I am absolutely loving this framework, y'all. It's so intuitive, and yet the structure is great. I'm going to repeat it one more time to help me remember it. We have child, content, calm, crowding out, and communication. In case I forget this until I've got it fully internalized, are there resources at the AAP that I can go to help me with this counseling strategy? Megan, can you help me out with that?
Yes, we do include resources around the 5 C's framework on the Center of Excellence on Social Media and Youth Mental Health website. And one thing I want to mention and express my gratitude to Dr. Rudetsky for her work and really building this out with such a developmental framework is that we do have resources by age range, because as we all know, discussions about ways to calm yourself might be different for a 4-year-old versus a 14-year-old. And we, with Jenny's leadership, really wanted to flush out individual areas by developmental stage. And so we're really hoping this will provide a useful framework that cuts across ages, but then individualize ideas and strategies by developmental stage.
This has been so helpful. Before we let you go, could you each give us a final takeaway about the 5 C's? Jenny, let's start with you.
Yeah. I mean, we're definitely seeing these as like handouts you might get at a well child visit and, at different developmental stages. And we really wanted to center it around what is your child doing in those stages? What is their little mind working on? Like, what are they trying to like master and accomplish? That's what drives development. And that's what, Megan and I both love about kids, as most pediatricians do. We're kind of like, what's going on in that little noggin? Like, what does this behavior mean? And we tried to really infuse that. I like this term called mind-mindedness. It's like a trauma-informed term of like, what's going on in that little brain? I know that their behavior may seem so irrational, whether you're talking about a toddler having a meltdown or a teenager who storms out of the room from you. And as a parent, part of you just wants to react and you feel bad that you're doing a bad job. But really what we do in child development or in adolescent medicine is say, like, let's get inside that kid's mind. Let's try to understand them and know what's driving them towards media. And then think of these other kind of tips of like, okay, if I wanted to build some healthy relationships with media, I really have to focus on content, calming, when I'm using it to calm down and avoid other coping strategies, what it's getting in the way of, and, does my family talk about this in a healthy way? So I hope it feels intuitive to families as well, not just pediatricians.
And Megan, do you have any last takeaways as well?
I think a last takeaway is that our goal is really to support pediatricians and parents in supporting the youth that they interact with, but we're also hoping to support parents and pediatricians as individuals. And the world of technology and media is one that we're all navigating, and we're hoping to really be able to support across the age span.
Well, I am just really excited about this whole structure, this whole development, and I cannot thank you enough, Dr. Jenny Rudetsky and Dr. Megan Moreno, for joining us today.
Thank you. It was fun as always.
Thanks so much.
To hear more about the Center of Excellence on Social Media and Youth Mental Health, visit our website at aap.org/podcast.
Coming up, we'll look at a cornucopia of QI in the journal Pediatrics. David, before we get started with the next segment, I just want you to take a deep breath.
Okay, but why?
You want to know why, David? Because today is our first ever segment devoted solely to QI, or quality improvement in hospital pediatrics. And knowing this is one of your favorite topics, I am so excited for you and all the QI champions out there listening.
Okay, not gonna lie, I may need another few deep breaths here. Who is our guest for this Coachella of quality improvement, this Burning Man of benchmarking, this leadership Lollapalooza?
Today we are talking to Dr. Michelle Nolk, Associate Professor of Pediatrics in the Division of Hospital Medicine at Oregon Health and Science University, and an attending physician at Dornbecker Children's Hospital. She's also the chair-elect of the Pediatric Acute and Critical Care Quality Network. Michelle, welcome to the show.
Thank you so much for having me. I'm happy to be here.
Can you give us a little background on the Pediatric Acute and Critical Care Quality Network?
The Pediatric Acute and Critical Care Quality Network is one of 3 quality networks within the quality initiatives of the AAP, with the vision of achieving high-value care for all children in all hospitals.
Well, as a pediatric hospitalist, Michelle, I am super excited about this. So let's start with one of my favorite soapbox topics, antibiotic stewardship. Can you tell us what the latest research shows us?
Sure. So I can share with you one of the quality initiatives that was undertaken by the PAC Quality Network a few years ago called BASIC, or Better Antibiotic Selection in Children, that was led by Dr. Rusty McCullough from the University of Nebraska Medical Center. And as I am sure your listeners are aware, nearly 25% of antibiotics that are prescribed to children are inappropriate or unnecessary and subject patients to avoidable adverse medication events and cost, and can contribute to antibiotic resistance. And so Dr. McCullough and his team put together a quality initiative that was implemented across 118 hospitals nationally, targeting improving antibiotic selection, including empiric antibiotics, definitive antibiotics, and duration of antibiotic treatment for 3 infections that are most commonly cared for in the hospital or acute care setting: pneumonia, a skin and soft tissue infection, or UTI.
All right, this sounds like an incredible study. So what did they find? And is there something we can do differently?
Well, interesting. So the collaborative put together a toolkit for each hospital to use and implement in their local setting to help promote better antibiotic selection. So these toolkits consist of a multifaceted approach that each individual site can then adopt and implement that for whatever works best for their local hospital setting. These interventions included things like audit and feedback with real-time use of run charts, so different sites could review what their own data is and compare to the aggregate data and track their measures. They created order sets for different hospitals to try and prompt the appropriate empiric selection of antibiotics based on local antibiograms. They provided educational webinars. They created a mobile app for users tailored to the local antibiograms that would help guide initial and definitive selection of antibiotics. And then there was also a coaching program that went to support the different hospitals in the implementation.
And how well did it work? Did we use fewer unnecessary antibiotics?
It turns out that we did. So after the 18-month implementation, Dr. McCullough and his team found that hospitals had improved in their empiric antibiotic selection for all three of the conditions.
That's incredible. And speaking of antibiotics and when to use them, I remember how groundbreaking the updated clinical practice guidelines on managing febrile infants from 8 to 60 days of age were when we reviewed them in episode 70. Have they made the lasting impact we hope they would?
Yeah, that is a really interesting. That was a huge culture shift for hospital medicine, away from kind of the standard routine evaluation for all infants presenting with fever, with the new clinical practice guideline really encouraging physicians to pause and think about risk factors and risk stratify infants based on different characteristics, including age or inflammatory markers, which was a huge shift in the practice from where we had been previously. Dr. Corey McDaniel from University of Washington School of Medicine and Dr. Paul Aronson from the Department of Pediatrics and Emergency Medicine at the Yale School of Medicine led a national QI collaborative through the PAC network called REVISE 2, or Reducing Variability in the Infant Sepsis Evaluation 2, where we worked with hospitals to implement the updated clinical practice guideline that was released in 2021. Dr. McDaniel and Dr. Aronson had 113 hospitals that enrolled and participated in this collaborative, and they developed a multifaceted, multi-layered QI change package that was delivered to these hospitals, reinforcing the implementation of these new clinical practice guidelines. And what they found that was with the tools that were provided, including clinical pathways to help guide decision making, again, education, webinars, they had very detailed coaching, one-on-one coaching, and the pod program that we have through our other collaboratives. They were able to achieve their specific aims. Launching this collaborative in synchrony with the CPG really allowed rapid uptake of these recommendations rather than trickle-down effect that we think takes upwards of 20 years after new clinical practice guidelines are released. Of the 4 primary measures that were selected by the project leaders, 2 of them exceeded 90% adherence, which is really impressive for a national QI collaborative. With the appropriate CSF obtainment, or appropriately not obtaining CSF for infants 29 to 60 days of age with normal inflammatory markers. And they achieved a mean rate of 92% for qualifying infants with 3 points of special cause variation over the course of the collaborative, which lasted for 18 months.
Well, Dr. Nolk, I think I was right to get super excited about this interview because the studies you're telling us about are extraordinarily successful. So I hope you can help me with one more struggle that I have on the pediatric floor, especially in winter. When to start kids on high-flow nasal cannula oxygen when they have bronchiolitis. For some places, that's an automatic transfer to PICU. Others use a weight-based standard, and I get confused. What should we be doing?
It is fair to be confused. The evidence has been back and forth over the last decade plus around high-flow use and bronchiolitis. And I think it is fair to say that not every patient needs high-flow nasal cannula, and yet our evidence hasn't really helped us identify those clear initiation parameters for infants with bronchiolitis to help us identify who is going to benefit from the therapy. And the fact that we kind of, as you mentioned, have this knee-jerk reaction to treat all of our patients who are admitted with bronchiolitis with high-flow nasal cannula makes us think that we definitely overuse that therapy in the management of these children. The last collaborative that I would love to share with you is the High Flow Collaborative, or High Flow Interventions to Facilitate Less Overuse, where we developed 2 specific interventions, one targeting high flow initiation and one targeting high flow weaning, to try and promote more judicious use of high flow nasal cannula. That was led by myself and Dr. Courtney Bird, who is a pediatric hospitalist at Emory University School of Medicine. For the initiation arm of that particular project, we created the High Flow Pause, which encouraged teams to pause before they initiate the high flow in infants with bronchiolitis and address elements of patient state, making sure that they had been adequately suctioned, that they were hydrated, that we were managing their pain control, that they were being soothed by caregivers if they were present, and to consider a trial of low flow nasal cannula prior to escalation to high flow nasal cannula. For the high flow weaning arm of the study, we implemented or created the High Flow Holiday, which was a twice daily trial off of high flow nasal cannula from any flow rate. And then what we found after the hospitals implemented these 2 new protocols, and these protocols were implemented across 86 hospitals with 71 who eventually submitted the full data, that we were able to reduce high flow initiation by 32% from baseline rates. And we were able to reduce high flow treatment duration by 28% in the hospitals that implemented the High Flow Holiday. One other really cool element of this particular collaborative that was a part of our toolkit was some online asynchronous education that our expert working group was able to create, called the Bronchiolitis Booster Series, which is an online series of videos and modules that cover bronchiolitis basics, epidemiology, the clinical practice guideline, updated evidence review for the use of high flow nasal cannula, and assessment of mild, moderate, and severe respiratory distress. Access to these videos was provided via QR code to all of the different participants, so they could easily and quickly access a just-in-time quick hit video around assessment of severe respiratory distress to try and help build a shared mental model for the team at the bedside when they were making decisions around if a patient needed to have high flow.
Well, Michelle, I wanted to thank you for doing this work. That was an incredible paper to hear about as well. And we've learned so much from you today. But do you have one last QI takeaway for us?
Sure. I would say my takeaway with quality improvement is that it is a team-based sport, and it is a wonderful way to build relationships in your hospital with interprofessional colleagues, with everyone with the same goal of improving the value of care that we're able to provide for our patients and families.
Dr. Michelle Nolte, thank you so much for talking with us today.
Thanks so much for having me. It was a pleasure to be here.
To read the papers we discussed today, just go to aap.org/podcast.
This week, our Say Ah is extra special because it's our 200th episode. So we decided to share with you what we love most about doing this podcast. David, do you want to start?
I would love to. And I have to tell our listeners, we have not talked about this ahead of time, so I suspect there's going to be some serious overlap here, but we're going to find out. Thing number 1, just the learning. As a mid-career physician, I live, honestly, in terror of getting out of date and just not picking up the new things as they come along. So I really rely on this podcast to stay up to date on developments as they roll in. And I can't count the number of times I said, we covered this on the podcast. You know, this is what's changed.
Oh my God. Or the amount of articles that I've shared with residents or fellows, because I read them here on the podcast first. I wait for the podcast to come out and then I'm just sending them out, you know?
Yeah, they all go into the, you know, when I trained, we had these big file cabinets of articles that we'd, throw in the copy machine. It's so much easier. You just shoot out that PDF. You're like, wait till you read this. You're going to love it.
And listen to this podcast too, because we sum it up for you.
Exactly. Number 2, I absolutely treasure working with this team. I know you remember when we tested our first podcast and sent it out to reviewers. One of them said, I just don't know if Dave and Joanna, have chemistry here. And now, if anything, our producer, Ann Johnson, has to get us back on track because we're having sometimes a little too much fun.
I text you and Ann probably more than I text my partner. I feel like we have a group text chain and listeners have to know about that. And we talk about everything. It's like where we share our family, where we share podcast ideas, where we tell jokes, where you guys share a lot of bird imagery.
Yeah, I do. I'm bad about the birds,
birding
but
as they get older.
They're so cool, Joanna. I gotta...
I mean, it's one of my favorite things to have this friendship with you guys, a true friendship with you, both of you. And I actually was like worried I'd cry talking about it.
There's still time.
Because it means so much to me.
I could not feel more the same way. It's just extraordinary. And then third, I have to say, just this opportunity to hear stories and share stories. We're all very attuned to sort of powering down a bunch of data and thinking through algorithms and decision making. But until you know how this affects individuals and what's happening in their lives, it's all very dry. And so this opportunity to just listen to so many people who are working so hard to make everything we do better is just an immense privilege. It's like a fantasy dinner party that just doesn't end.
I wanted to add, I have a thing to add, because obviously your 1, 2, 3 are my 1, 2, 3, not in that order in time and space. But the people that we get the privilege of meeting on this podcast, and I often think about my privilege. I mean, these are incredible minds. These are generally pediatricians who are so invested in their work, and we build relationships with them too. I mean, the relationships that we have with Rachel Lewis and Alex, who are our podcast regulars, I mean, that also feels like family, and there's so much love there. David Kimberlin, who's been on a few times, has given me medical advice about infectious diseases. And it is such a privilege to have access to all these incredible minds and these wonderful people. And it really just, I've said this a million times. I mean, pediatricians are the best people. It was just really an incredible network that it's such a privilege to be a part of. And that is one of my most treasured things about working on this podcast.
Completely.
It doesn't feel like work.
Not
David, it feels like
this is a blast.
Hanging out with my best friends, getting to learn from incredible people. I mean, it's a privilege to even do it. This is my dream job.
Absolutely. And here we are.
Yeah, and here we are at episode 200. I cannot believe it. I'm so thankful to everyone who is listening. I'm going to cry again. Because it's just, and our listeners, people who come up to me who have actually listened, who want to engage in the content, who want to have real conversations about the topics that we discuss, which can be really difficult to discuss sometimes. I mean, that is also a huge privilege. So our listeners, thank you. You make this possible, these incredible things.
Absolutely. Without the listeners, we are just talking to each other. And that's fun, but it's not a podcast. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about the new edition of the Red Book.
We'll speak with Dr. David Kimberlin about the latest and greatest from our favorite resource. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Malinky. Thanks for listening.